So good morning. I am Matthew Hart, CEO for Longwoods Publishing, and I'd like to welcome everybody here this morning. A couple quick little points, and then we'll get on with everything. I am a big proponent of networking, so if I've not met you, please feel free to introduce yourself at any point in time. For those of you online, there are a lot of people online this morning. I'm available on LinkedIn. So is everybody else here. So feel free to network. It's an important aspect of our jobs, and you never know what you're going to learn. You never know when you're going to meet somebody and need somebody to help you with something. For those of you online, you're missing the opportunity to network with people here. You're missing breakfast. You're missing coffee. If you're in the GTA, when people, not just even Longwoods, anybody, if somebody is doing an event, go out to it, enjoy it, take advantage of the networking. So before I hand it over, I would like to thank Healthcare Excellence Canada for supporting today, ICES for supporting today, Canada Health Infoway, Extendicare, Health Pro, IQVIA, and in the audience, of course, is Steve Lowe from LBCG Consulting. And supporting today and offering up their facility is Deloitte. And Niraj would like to say a few words and welcome everybody.
Thank you. So I was parachuted last minute, so I have to admit I'm going to read some notes here. But welcome to the Deloitte offices, and good morning. I'm a partner in our AI and data team, and I lead a lot of our healthcare AI work. So as you can imagine, I am embedded within the chaos of information and misinformation, and how do we make sure that these AI models can be trusted? And trust is the number one factor that keeps coming up every time we deploy or talk about AI these days. And, you know, trust has always been the cornerstone of healthcare, as we know. And yet in this world with overflowing data and information and evidence that's out there, and every minute there's data that's being produced out there, we find ourselves in a bit of a paradox. More information is good sometimes, and the scientific evidence that comes out, and research, and even what we called data that is created from a synthetic perspective for us to train AI models. We love them because then just not enough images out there as an example. And if we can create synthetic data of more images, we can train better AI models. But then how do we trust those data sets? How do we make sure that it's not produced by the deep fakes of the world that we're seeing right now? So there are a few principles that we've seen being implemented that has kind of worked. And obviously, this is an evolving space. So we're continuously researching and how do we make sure that we build trust? First, say transparency. That's our default. And when we say default, it means that we must begin with transparency as opposed to building something and saying, well, let's be transparent about it. So we must be clear about where our evidence comes from, but more so, how is it generated? Who funds it? These are important questions that that comes to us. So it's not just about the what, but the why and the how that builds transparency. Secondly, context matters. So evidence does not speak for itself. As we know, it must be interpreted with clinical judgment, cultural awareness, patient values. These are things that comes up when we talk to clinicians about building an AI model or trusting them with a tool, a technology that they must use. What patient values were taken into account? How was bias addressed? What ethical judgments were put in place? So context really matters. And then thirdly, we must include the voices of the people we serve. We must co-design. We must co-build. And this means communities, patients, frontline clinicians, and that's the sort of the cornerstone of how we do work here at Deloitte as well. We're building out something with the Ottawa Hospital right now. It's a conversational AI for patients to have an interaction with. Only 10 to 20% of heart failure patients who go back home after discharge get a check-in call because nurses are not available. So how do we make sure that we reach 100% of patients? And nurses should not be making check-in calls. They should be serving patients bedside. So we thought about a conversational AI tool that can talk to patients. But we need to make sure that this is built, keeping in mind what nurses do, how they show empathy, how they are human-like perhaps, and what patients really need. How can they trust this conversational AI tool? This project is led by a nurse, not by IT or tech. And the co-design is a key factor that comes into place throughout the whole process of, we start with a hypothesis and it ends up being something very different, but something that will be adopted. So the last point I want to just bring is humility. We have to embrace humility. Science evolves, data evolves, evidence evolves, and recommendations change. And that's okay. And what matters is not perfection, but a commitment to continuous learning. And that's what we communicate, even especially in the space of data and information and my space of AI. We're not coming in and saying, well, this is perfect and you must use it. No, it's by no means perfect at all. It's about continuous learning. It's about finding those small productivities and efficiencies and values that a health system needs. So I'll just leave it there as a bit of a opening and context, and I'll pass it to Helen.
Terrific. Thank you very much. Great to be here today. I'm Helen Angus. I'm the CEO at AMS Healthcare by day, and I'm also the board chair at ICES. So great to have my colleagues here. So the topic today, I hope you're all in the right room, for when evidence no longer speaks for itself, reclaiming trust in a world of information. And the thesis here is that the noise and uncertainty resulting from what I would propose is a new cadence of misinformation and disinformation is impacting where and how people get that information, who they believe, and ultimately, and probably more importantly, that it actually is, we're at a point where we're putting the health of Ontarians at risk because of this phenomenon. I'm hoping that in the hour that we're spending here today that we can explore some ideas about how we can cut through the noise and restore public trust in credible scientific information. So if I do my job well as the moderator here today, we're going to try and answer some questions. What is the current situation of misinformation and disinformation? Why is the erosion of trust not new for some communities who have faced historical harm in the name of science? How did our experience in COVID-19 accelerate mistrust? And where are we today with new threats like measles? So that's on top of the fold a lot of mornings. And then how can we reclaim trust through leveraging AI technologies? And I think we just had a really nice introduction from our colleague at Deloitte. So a few thoughts from me, and then we'll get to the panel and the people you really came to see, which is Michael Schull and Chris Simpson to my left. So what do we know? We know that disinformation in science, so false information that's deliberately spread with the intent to deceive in the world of science is actually a fairly rare phenomenon. It can occur and it can have impact, especially if it's amplified, through the media, politics, or corporate interests. And that has an impact on corporate trust. The good news is in the world of science and science production, we have pretty good processes, peer-reviewed journals, ethical standards, disclosure that set a pretty high bar for the production of scientific information and knowledge. I think the bigger challenge is the presence of disinformation in the public debates around science. So think about climate change denial, anti-vaccine propaganda, or misinformation around pandemics. And that can come from a number of sources, right? Politically, ideologically motivated groups. You just have to cast your eye south of the border and you see a fair bit of that. Corporations that might protect their interests and profits. And then the social media has an increasing role in amplifying some views unfounded in science. And again, we've got some pretty good examples of those, whether that is the tobacco industry knowingly suppressing or distorting research on smoking risks. That's an historic example. Climate change denial campaigns, which have funded disinformation to question legitimate science and scientific consensus. And during COVID-19, we saw, disinformation spread rapidly about vaccines, treatments, and the virus itself. But I would say that we're probably in a new era where the volume and velocity of misinformation and information is increasing. those who are in most need of good scientific information find it the hardest to access. So the net effect is an erosion of trust in research and evidence, and the health impacts can be significant. I certainly saw this during COVID-19 from my perch, particularly around vaccines. It was hard to achieve a level of trust with some communities, particularly those most vulnerable to the pandemic. We saw amateur citizen scientists on social media running their own numbers on the shape of the pandemic curve, really, and sometimes contrary to the very careful and thoughtful advice of the Ontario Science Table. And we saw misplaced trust in a treatment for parasites as a treatment for COVID. So that's the challenge. I think the good news is that we don't have to be passive observers of information chaos. And in the case of vaccines, there was some very careful work with the ministry, Ontario Health, the Health Common Solutions Lab at Sinai, working with and within communities to point out the key role of community ambassadors as kind of the last mile relationship manager in terms of getting scientific information and good health information into communities that had probably some pretty good reasons for distrust. And their role as interlocutors, I think, has achieved considerable success. I need to switch this out. All right. How's that? Better? Yep. Okay. And there's lots of other examples, which my colleagues will explore today. So joining me, I've got two fantastic leaders, Dr. Michael Schull, CEO of ICES, and Dr. Chris Simpson. I do know your name. I just want to make your get your job right. EVP and Chief Medical Executive at Ontario Health. And Michael, I'm going to start with you and your perspective as leading an organization that produces high quality scientific information.
Great. Well, thank you, Helen, and thanks to Longwoods and Deloitte for hosting this, and thanks to everyone who showed up in person and online. It's terrific to be here with you this morning. So, yeah, I'm representing a research institute. ICS uses population health data on the entire population of Ontario on a routine basis to study all sorts of issues that relate to the health of Ontarians, and publishes hundreds and hundreds of papers every year. And we need to find ways to effectively communicate those papers. So this issue of misinformation, of loss of trust, of kind of the information overload that exists, and misinformation, the presence of misinformation, is something that we have certainly been aware of for many years, as we all have. But I think that the threat and the impact on health and public health has grown recently. And, I don't think we should be surprised. I mean, we live in a world where just about every traditional method of information dissemination has been disrupted. I mean, my kids don't read the Global Mail when it comes every morning anymore. They may read it online, but if they do, they probably don't recognize it's coming from the Global Mail versus something else that they might see on their feeds. So it's not surprising that the communication of science is being disrupted as well. And I think it's up to us to adapt to that. It is important, I think, to underline that the traditional methods of research dissemination, which is publication in peer-reviewed journals, remains critical for scientific credibility. It's the way that we subject our findings to informed scrutiny of our peers. And I guess, it's a bit like Churchill, who said that democracy is a terrible form of government, but it's better than all the alternatives. Similarly, traditional peer-reviewed publication is not a great way to disseminate science. It's slow. There are barriers to entry, which have increased over time with, non-open access journals and so on. Nonetheless, in terms of ensuring that research results are properly scrutinized, it remains important and critical. But if what we're trying to do is to affect people's behavior, or to increase the uptake of a proven intervention or therapeutic, or to try to get people to stop doing something that is bad for them, simply publishing a paper or a study in a peer-reviewed journal won't cut it. We've known that for a long time. I mean, it's not as though this is a new problem where the results of publications are not having the desired impact in terms of changing health behaviors and so on. But the problem has gotten worse because we live in a world of atomized information, where not only is there science out there that's perhaps not being taken up as much as it should be, but in addition to that, you've got all of these other sources of information and misinformation that are hitting the public in their everyday lives. we know that people are sometimes searching in the wrong places to get information. And this can often be when they just can't access care. So, if you don't have a family doctor or a nurse practitioner, or can't get in to see your family doctor because of long waits, if you're sitting in a queue to get or see your family doctor, it's not unreasonable for someone to turn to the internet and say, well, can this provide me with the information I need more rapidly? And unfortunately, the internet is now a minefield, filled with both reliable and unreliable information. And I think it's up to us to not try to tell people not to go on the internet, but rather to try to guide people towards more trustworthy sources of information and avoid the less trustworthy ones. And this is, of course, a problem because, we like to portray ourselves as trustworthy institutions. We represent science and universities and research and all these great institutions, but people's faith in all of these institutions has diminished over time. And we need to recognize that and try to adapt and communicate in ways that will help to rebuild that trust or perhaps gain it for the first time. We know also that both the loss of trust or the lack of trust is not evenly distributed across society. There are specific communities for historic reasons, for systemic reasons that relate to racism or other factors that mean that some communities are less trusting in institutions. Their experience are more negative with institutions than other communities. And we need to therefore adapt our methods of communication. We also need to think about who's doing the communicating. How do we engage with those communities so that members of those communities are actually the ones who are communicating back to those groups? We're seeing this impact in all sorts of ways. Measles was mentioned. The fact that we have an outbreak, the worst outbreak in Ontario in more than a generation, is a direct result of misinformation, of loss of trust in vaccines. And we know that the seeds of that were not planted during COVID. They were planted in the 90s when the first studies came out. Actually, I shouldn't say the first, but certainly the most notorious studies came out that claimed to show a link between measles vaccine and autism, which were subsequently debunked. But in fact, those ended up in peer-reviewed journals. And so that you could argue then perhaps about the quality of peer review. So I think as researchers, as members of healthcare research institutes, we all have a responsibility to try to address this. But one other factor that we need to think about is what are the incentives and how are they aligned or misaligned with this effort to address misinformation? And what I mean by that is when you look at how a researcher is rewarded in their career currently, it's typically not because they've got a great podcast or they did some good TikTok videos. It tends to be around publications, grants, the very traditional research metrics, which are of course critically important. But universities and institutions have to adapt to reward these other forms of research dissemination, I think, to begin to tackle this flood of misinformation. We ultimately need to meet people where they are because most people are not reading the New England Journal or BMJ or CMAJ. Most people are on TikTok or in other forms of social media. Just one other thought before I turn it over to Chris. I think we also have to be aware that we can't put the onus all on individual researchers to be able to do this. As representing institutions, our communications teams, our knowledge translation teams have to also be engaged in this fight. We have to support researchers. We have to also recognize that there's a toll that can be taken. I know a colleague of mine who published studies during COVID comparing outcomes of unvaccinated and vaccinated individuals and was vilified, got just an endless stream of abuse and insult on social media, snail mail, you name it. We had to increase security at the institution for a couple of weeks just to be sure, although it never came to physical threats. But this takes a toll. And so if we're going to ask people to be out there in public, communicating better, all this stuff, how do we protect them against that toll? And I guess the last thing, as an organization that does its own research, it's hard for us to say to the public, don't do your own research. Rather, I think what we need to be doing is telling people, yeah, do your own research, but let us help you make sure that it's with trustworthy sources. And how do we do that? I think that's an essential challenge.
Great. Thank you, Michael. So Chris, you are in a leadership role in an agency that has a clinical focus. So perhaps explore the topic from that perspective. Thank you.
Yeah, thanks, Helen. And I certainly agree with everything that's been said so far. It's been a great introduction. Ontario Health is a Crown agency that was put together from several legacy agencies with, I would say, trusted brands, although we can talk about that a little bit. But if you think, Cancer Care Ontario, the Ontario Renal Network, Health Quality Ontario, David Kaplan is here today. These are brands that were known. And so Ontario Health was the super agency that aimed to bring all of these things together. And we operate the system. So you think about the ministry as sort of setting policy. Ontario Health is meant to operate the system. And we do this based on evidence and with input from frontline clinicians and from patients and caregivers. And the aim is to develop a system that delivers the best quality and the best value for money. Our primary audiences are the healthcare sector and healthcare provider organizations, as well as practitioners. And we have products like quality standards and guidelines and practice tools that help frontline people deliver the best kind of care. And because these are so carefully done and based in evidence, the practitioners who use them can have confidence that these are based on good information. And then in turn, the patients and clients who are the beneficiaries of these of this work can have confidence that that they come from the best information. We also aim to connect and coordinate the system. And I think at no time was this more evident than during the pandemic, which none of us really want to talk about. We were talking about our PTSD about this earlier. But if you remember, at the peak of the pandemic, when we were transferring patients from some of the really hard hit hospitals, that was really, I think, Ontario Health at its best, acting as a system. And I think we did it, perhaps better than many others. But, I agree with everything Michael has said, but I just wanted to reflect a little bit on some of the backlash that we had during the pandemic. Backlash against masking, against vaccine mandates, against travel and work restrictions. And I think this really served to accelerate the receptivity to misinformation and the generation and the spread of disinformation. People basically over time grew really weary of being told what to do by the experts. And this isn't to suggest, as Michael has very well pointed out, that the pandemic caused this. Misinformation's been around forever. If you ever get a chance to visit the American Medical Association website, they've got this long history of, the old traveling shows with the potions and stuff. And they sort of created their organization around kind of combating misinformation. So not a new phenomenon, but the pandemic, really sort of served to accelerate, I think, the misinformation environment. And it was all fueled by social media and the increasingly sophisticated algorithms that drove people into these echo chamber communities. So, this was all a combination, I think, of extremely understandable reaction to the significant disruption that we had. There was, a perceived by the public disregard for some of the concerns that were being expressed by things like school closures, for example, and that we were sort of ignoring the unintended harms that were sort of underway in real time. And just to be a little bit provocative, I think many people would say that we, the expert community, not to suggest I'm an expert in anything, because I'm not really sure that I am, but the expert community kind of failed to communicate with sufficient humility and deference to the people that we serve. And so even though there were tons of really good communicators out there, you think about people like Staney and Isaac and Fahad, and I mean, these folks and many others are best in class communicators. But I think there was still this sense, especially because of the duration of the trauma, that that there was some tone deafness and a little bit too much thou shalt kind of tone coming from the community. So all of this is to say, and I don't mean to be too self-critical, but the major lesson for me to be learned from the pandemic is humility, and the fact that we need to embrace our duty as experts to serve rather than, you know, tell people what to do. And I think Michael was saying much the same thing. That really means, you know, listening to what people are telling us, and that's the way that we engender trust. And then once we have the trust, or, you know, if we can maintain the trust, then we can have a chance in this crowded information environment to put the products out there that that people can use, and that they can have you know, good and reliable and trustworthy information to consume. And there's also pretty good evidence that that debunking works as well. You know, I think many people believe that, you know, we shouldn't sort of give airtime to some of the more crazy sounding things that are out there. But there is good evidence that when you you know, when you carefully debunk and then replace it with good information, that can be effective. But I would hasten to add, you know, that has to be done with a lot of caution, because increasingly a lot of misinformation is tied to identity. You look at some of the data from the US where political identity is really very attached to some of this misinformation. And so when we challenge somebody's belief, we're often challenging their very core self. And so we have to be very careful when we challenge these beliefs, that we're not doing it in a way that that disparages somebody or threatens their identity. So I'll just finish the introductory comment by saying, you know, on a broader scale, I think we see misinformation and disinformation working to undermine the credibility of scientific institutions and bodies whose job it is to rigorously weigh the evidence and to make recommendations. And introducing this doubt leaves people with just enough a doubt, and you know, to say, maybe I need to look somewhere else for my information. And it leaves vulnerable people, and Michael and Helen both alluded to this, particularly vulnerable to other sources of information that are factually incorrect. So the challenge is to figure out how to get, you know, lots more information into the space for consumption, and to really build on the trust that we have. Some of that is restoring trust. Some of it, I would argue, is building trust. I'll finish there.
That's great. Thank you. So just thinking about how to unpack this very big topic, why don't we talk a little bit about what we know about what makes people more or less susceptible to misinformation and why, and then we'll get to some solutions. Michael, I might start with you.
Sure. Thank you. So I don't claim to be an expert. I think I'll just start by saying I think it's important we don't kind of blame people. It's, you know, it's their fault that they're falling, you know, prey to this misinformation. It's not the fault of the public, and it's really our job to understand why this is happening and try to develop ways to address it. As has been alluded to a couple of times, you know, this loss of trust is not necessarily new. In some cases, for some communities, the trust perhaps has never been there. And so really, I think it's just an underlining of the fact that we need to build trust, rebuild trust in certain instances. And that is a challenge when we are working with communities where there has been historic harm done, whether those are Indigenous communities in their encounters with the health system, or Black communities among others. We know that there is often low health literacy broadly. I mean, even individuals who are not necessarily falling prey to misinformation may still suffer from low health literacy. And so I think we need to find ways to convey messages in ways that are understandable to the public and can somehow get through the clouds of information that people wade through on any given day. From a research perspective, we probably don't pay enough attention to converting our findings, our results, our conclusions into language that's understandable to the public. You know, I think I was trained very well on how to give a 10-minute PowerPoint presentation that summarizes a study which has about 5 slides on the methodology that even some peers may, you know, understand. Even sometimes I'm, you know, if I've got some high-end statistician working with me, I'm not even sure I totally understand it. But not really, I wasn't really trained well to ensure that my results are understandable to a broader audience. And I'm not sure that we're necessarily doing that better a job today in training researchers and scientists to do that well. So I think that is something that is a challenge and will make people more susceptible to misinformation if they can't understand what we're trying to say. I think we also need to think about not having a one-size-fits-all approach. It's, you know, the information that works for one group or one community, one age group, one racial group may not work for another. And so we have to nuance our communications. And I think that is not just an effort at addressing misinformation, but also at influencing health outcomes. And a great example of that was during COVID, when some of the work that we were doing at the neighborhood level to look at COVID infection rates found that, you know, there were higher rates of COVID infection in more marginalized communities. And at the time, I can recall there was misinformation that were blaming those communities, whether it was around religious festivals that were taking place, or, you know, people were just not, you know, wearing their masks properly. Well, in fact, the issue was that many of those people were frontline workers who had to go to work in grocery stores or on the TTC or in nursing homes or hospitals, and were being exposed to the virus and getting sick. So hence they had higher rates of infection. So that's a form of misinformation that we can do a lot to combat. And similarly, when the information around vaccination rates, when vaccines began to roll out, you know, you saw that in those communities that had higher COVID rates, the rates of vaccination were often lower. And that, again, was about a one-size-fits-all approach to the vaccine rollout. And to their credit, public health units, Ontario Health, the ministry responded to that data and changed the way that they were rolling out the vaccine in communities. Much more engagement with the local communities, working with religious groups or social groups to both translate the message, pop up vaccination clinics. And we actually saw in the data a very rapid shift in those numbers, with the rates of vaccinations catching up in those communities. So again, is that about misinformation, or is it just about the way that we're conveying information? So I think there's a lot of work that we can do in that regard. This obviously takes time, right? Building trust, combating misinformation doesn't happen overnight. It's not. There's no switch we can flick. There's no one technological solution. And unfortunately, I think we tend to do it, you know, when there is a crisis, that's when everything starts to happen. And that's probably not the best time to be trying to build trust in the midst of a pandemic, in the midst of lots of anxiety, when none of us are probably at our best. So how do we do that in normal circumstances, in peacetime, so to speak? Right now, how do we continue to do that? And I think we're going to talk about a little bit about some of those solutions in the next question. But certainly, I think that my main point would be, let's not blame people. Let's actually work with them and meet them where they are.
Chris, over to you.
Yeah, I certainly agree with Michael's points. I think, you know, it's critical to avoid blaming people for their exposure to misinformation. And he's precisely right about, you know, the deep-seated racism in the system that is historically done, you know, great harms to Indigenous communities and Black people and others. And that has really fed this legacy of mistrust. But, you know, I think one thing about the way we present evidence to the public, just picking up on Michael's point, both collectively and at the bedside, you know, speaking as a clinician, is that in our enthusiasm and confidence, we often create the impression that science provides the answer and that there's no room for discussion or context. And we often generate these recommendations in a sometimes rigid and prescriptive way. And sometimes that comes across as leaving patients and families out of the decision making. So in my area, cardiology, for example, you know, you have a heart attack, so you leave on a statin, an ASA, and clopidogrel, and a beta blocker. And then we rush them out the door. But what we often fail to hear is that this patient's brother has done some online research and says, you know, that all doctors are in the pocket of big pharma and they take a cut from all these from all of this medication. It's some big pharma scam, and we're, you know, unaware that the patient's own research has sort of and the algorithms that he's exposed himself to have led him into these echo chambers that are touting natural therapies for heart attacks and offering him, cleanses and vitamins that will restore his heart to health, and bombarding him with information that kind of feeds his confirmation bias. So that's the part that's missing, and I think the other thing that really is so compelling about this is that it's often accompanied by these personal attestations and narratives, right? And that where patients can say, "Oh, that sounds exactly like me." So I'm going to listen to this online source. So as was said during the introduction, the democratization of information has been really a very wonderful advance in many ways, but social media, along with the proliferation of health influencers, have found ways to really capture people who just have a healthy skepticism about what they're being told, and they're capturing them and they're bringing them in to these ready-made reassuring answers to their problems. And it often sounds too good to be true, and that's precisely because it is. But that's really the source of the allure. But when people fall ill, what they crave the most, apart from being well again, is basically to regain control and to have some certainty. So they'll say, there must be something I can do to remedy this, to be my old self again. And there are lots of people out there who are ready to exploit that very deep-seated desire naturally, without drugs, without the conventional, profit-seeking healthcare industry. And the charlatans out there, that's a bit of a tough word, but let's call them that. They've co-opted science-y language like microbiome and quantum and detoxify. And you'll hear ads on cable and radio that say that a product has been clinically proven. And even though at the end of the ad, there's this disclaimer, this product has not been approved by the FDA, blah, blah, blah. So the sciencey language, and Timothy Caulfield writes a lot about this, gives the product the air of legitimacy, things that'll restore your natural pH or cleanse your liver of toxins or boost your natural immunity. And when these messages are delivered by a celebrity influencer, then the impact is amplified even more. So, the wellness industry in Canada is a multi-billion-dollar industry. I have no doubt that it started and is still occupied in at least some proportion with folks with noble intentions and with some efficacy. But it's quickly been found and exploited by those who understand that people will pay a lot of money in an attempt to get control over their illness and their symptoms. They're experts in telling people what they want to hear in the way that they want to hear it. They question the motives and the honesty of conventional practitioners and evidence-based treatments just enough to seed doubt, and that in turn primes people for the subsequent bombardment of misinformation and disinformation. They exploit the hardwired human predisposition to be swayed by narratives and firsthand accounts rather than epidemiology and clinical trials, which of course exist precisely to protect us from our own biases and our own preconceived notions and our own intuition. So they create compelling solutions by understanding and exploiting our fears, and they're very good at it.
All right. So let's seems like that, but I think there are things that we can do, and let's try and move towards like some solutions, because dealing with hardwired human behavior is tough, but I don't think it's impossible. So let's explore how we can actually rebuild public trust in evidence science when misinformation spreads faster and more widely than facts, and obviously has a propensity to become adopted in particular ways in the human brain. In other words, what are you doing to reclaim trust in the world of information chaos? And Chris, maybe I'll start with you as a jumping off point.
Yeah, no, I think what you said is absolutely true. Misinformation spreads faster and more widely than good information does, and I think that's for a couple of reasons. One is the sheer volume of misinformation that's out there relative to the volume of good information. And secondly, the amplifying impact of social media and search engine algorithms. So people, so easily get sucked into echo chambers and rabbit holes, and it's very difficult to pull them back once they're persuaded that something that's false is actually true. So part of the solution, I think, is to generate and disseminate high volumes of good information. And healthcare leaders and institutions have a responsibility, I think, as Michael has said, to take on this communication function. I still believe that we're in Canada very fortunate that our institutions are still largely trusted, in sharp contrast to what's happened in the US. So we all need to take responsibility for amping up our communications, and that includes working together between organizations and partnering. And then, the other part of the challenge, and I think Michael has said this as well, is to change the way we communicate. So, prominent healthcare leaders and influencers now are becoming very savvy in their communication. So you think of people like Tara Kieran and Peter Lynn on CBC. They understand that good communication of good health information that's based in evidence and science must, first of all, not condescend. It can't belittle. It can't blame people for having been influenced by misinformation and disinformation. They understand that it has to use language that means something to the people that they're speaking to. So I mentioned earlier that practitioners of misinformation often use sciencey language to confer legitimacy. But, we scientists too often, I think, use scientific language in a way that conveys some message of superiority. I don't think we mean it that way, but it's often taken that way, as if to say, look at all the big words I can use. I'm an expert, so you should listen to me. So, that's kind of fundamentally disrespectful, I think, to the people we serve, and it drives people away, especially if they were a little, skeptical to begin with. And then the third thing that good communicators understand, I think, is that we really need to shake off all the remaining vestiges of paternalism in our institutions and in the way we interact clinically with patients. Because, ultimately patients need to be empowered, and Michael has said this, to lead in their own decision-making for their own selves. Our job is to give them the information they can count on. So we need to sort of turn them away from misinformation, give them the information that they need, but then trust them to apply this through their own value lenses and their own priority lenses. And then it's our job to support them in their decisions and work with them to help design their health plans. So for healthcare providers working with patients, the top priority should be to maintain trust and to keep the therapeutic relationship intact. And that's much more effective than fighting every misinformation battle in real time with the patient. So, yesterday in clinic, for example, I was signing a patient up for a procedure, and she said that she and her partner were practitioners of numerology, and there were certain dates where the procedure would be much better. That's very easy for me to accommodate. I'm not going to say, what do you mean numerology? And we don't do it on these days. That's so easy for me to accommodate, right? So the idea is to have them leave the encounter with you with the therapeutic relationship intact. It's not to win the battle. It's critical to never ridicule a person's beliefs. Instead, you counteract with what is proven to be true, and avoid all signs of condescension, and be careful of your body language and your facial expressions. Any furrowed brow or shaking of the head, or smiling or kind of laughing, it can be incredibly damaging to the therapeutic relationship. And I'll just finish by saying, I think at OH, I often reflect on the values. Every organization has a mission, vision, and values. One of our core values is humility, and I've mentioned this before, and that's a shared value with the scientific community. We always have to be prepared to challenge what we think as more information comes to light, and somehow we need to be simultaneously confident in what we're saying when we're giving advice, while being open to changing the approach if new evidence arises. And the public, often sees changing scientific consensus as evidence that we were wrong. We got it wrong. So we need to do a better job of communicating with the broader public around why our willingness to change what we think based on newer, better evidence is exactly why our institution should be trusted.
Thank you. Michael, same question. I do know something about Longwoods events that we always end on time, right? So we're going to, I'm going to then pivot to the audience and see whether you have any questions, because I could ask these two questions all day. So Michael, why don't you go ahead, and then we'll see if somebody has a question.
Sure. So I'll try not to repeat Chris's great comments regarding how to combat misinformation. I'll just say a couple of things. One is, you know, misinformation, one of the reasons why it's so attractive is that it has emotional impact. There's often a grain of truth somewhere in it that you build the lies around. It's often novel, simplistic, it's kind of sexy, it's interesting. And that makes it appealing, and people like to read about it. So one of the things I think that we have to make sure not to do as we try to combat it is to sort of imitate that, to try to make the truth more interesting by embellishing. And I'll just give you a quick example. When I began as you know, CEO at ICS, one of the things that I would do was to review all the press releases that were going out about various studies, because that was in the day when the way you want to disseminate to the public was to get your story picked up by the health reporter of the Toronto Star or CBC. Of course, there are hardly any health reporters left anymore, but that's not the way we communicate anymore. But one of the things I used to always try to pick out of those press releases was the kind of exaggeration or the sexing up of the results. So the classic one was there was 100% increase in outcome X when the absolute numbers went from 0.1% to 0.2%. Right? That's 100% increase. That sounds really exciting, but in fact, it's not that meaningful at all. So, you know, looking carefully at how we convey information to make sure that we're conveying the truth, but doing it accurately and not imitating misinformation, I think is one way to actually combat misinformation and ensure that the information that we're providing is trusted. Explaining what we do, how we do it. Don't keep this mystique, this veil between the actual results and how you arrived at them. Explain better to people what we do. That transparency, I think, is key. It was alluded to in the opening comments. So letting people understand the methods that you use, and I'm not talking about the detailed statistical methods, but where does this data come from? What does it represent? How is it that you even have that data? What do you do with it? I think that is an important part of building trust, is to demonstrate transparency, and do so by engaging with real people, having real conversations, understanding their concerns and their worries. I agree with Chris about humility. I think we never can demonstrate enough humility, and often we don't demonstrate it really effectively. But part of that is acknowledging the uncertainty in science, the fact that these are our results, but we can never really be 100% certain about them, and so they may change. And I think that's, you know, masking during COVID was a great example. At the very outset, the public health authorities were saying, no, we don't need a mask, and then it switched, and we do need to mask. And you know, that sort of uncertainty, I think, is something that undermines. So I'm not saying you do away with it, because you can't, you can't, but I think we can do a better job of acknowledging it and helping people understand why that uncertainty is actually how we learn. I've said earlier, you know, combating misinformation is also about changing how we communicate, the modalities that we use to communicate, training our researchers, our clinicians to communicate better, thinking more clearly about who's doing the communicating. You know, we talk about communities that are more at risk of both bad health outcomes, health inequities, but who is doing the communicating? Do those individuals, do we have a diverse enough cadre of researchers, of clinicians who are coming from those communities, so they can be, so that that people will see themselves in the people that are trying to convey these messages? Finally, I do think technology can help here. I mean, I'm not a Pollyanna when it comes to what AI and large language models will do, but actually, I think if we have well-regulated, well-designed, well-governed AI systems, they can actually help us combat misinformation. You can have a conversation with a large language model now. I do it in my shower in the mornings often. While I turn on the Copilot and ask a few questions. It's remarkable how natural the communication is, how empathetic that voice actually feels. I know it's an LLM. I'm not an idiot. I know it's not really feeling empathy, but boy, I feel it like it's feeling empathy towards me. And you know what? When I'm having a conversation with a patient or a family member, who here has a family member who is perhaps questions vaccine efficacy and right? And how many of you have had difficult conversations with them? You don't have to put up your hands. I do. And I know that my empathy lasts about 45 seconds with this person because I'm so close to them. Well, that Copilot will go on for hours with, my relative and not lose that empathy. Now, whether they ended up in a hallucination is another question. Anyway, I think in the interest of time, I'll stop there.
It's great. I'm thinking somehow we've programmed Norman Vincent Peale into your shower every day in every way. I'm getting better and better. So there you go. I could use that myself. All right. Questions from the audience. All right.
So we'll start actually here. So if you have a question, please wait for the mic, and so everybody online can hear.
Hi. So it was Mother's Day this week, and I wanted to talk about women and how we often fall victim to misinformation. And I think the root cause of falling victim to misinformation is really because there's not enough information. A lot of times there's not enough research on women. But there is research, it's on reproductive health. So I was wondering, what can we build trust on for populations that are significantly failed by our system? And what do we build that trust on when there is just not enough research or other good quality information to fall back on?
Okay, which of you is going to take that?
Well, I think step one is, I think for certain groups, women, or for Indigenous communities, Black communities, marginalized communities, however defined, the first sort of bar is to make sure that we use the information that we already know. I certainly accept your premise that there's insufficient knowledge for some groups. Cardiology is a very good example of how we've applied, data that were generated largely from clinical trials that were overrepresented by men, and have applied that to women, to women's detriment. But there's been, a lot of really good work done in recent years that show, the differences between outcomes in men and women and the different approaches, and we haven't sort of applied that well. So I think applying what we do know for certain communities is sort of step one. But I'd leave it to Michael to talk about how we can sort of encourage, and accelerate knowledge generation to better serve those underserviced groups.
Yeah, so I don't. Again, I have the solution. I think I'm thinking about Paula Rochon, who is a physician and researcher at Women's College, who leads a sex and gender research program, has done so for years. And one of the hallmarks of their success is that now when you apply for a grant to the CIHR, Canadian Institute of Health Research, if you're applying to do a health research project, you have to answer the question, how are you going to incorporate sex and gender into your analysis? And you need to provide a response. And I won't say that in every study it actually results in a detailed enough analysis, breaking down by sex and gender. But it is an important step. It's an acknowledgement of the importance of this. So I think that's number one. I think we need to look at, what is the research that we're funding? Are we actually putting enough of our resources? Because ultimately the priority is going to, where the money flows is what determines what the real priorities are. So when we're looking at health research in particular, are there gaps in terms of the funding for sex and gender research? And I think the answer is yes. And so how can organizations like the CIHR address that? Institutions like ours have a role in establishing research priorities. Now, in our case, health equity is an important research priority, and I think that equity between men and women and different genders, I think, is an important part of health equity. So it's up to us to put actions behind those words and demonstrate how we are achieving that. And I'll just related to sex, of course, is gender. One of our challenges is there's pretty good data about sex. There's not good data about gender. And so that is an area where we can work with our partners in the health system and elsewhere to gather better data about gender, so that we can understand and shine a light on the health issues more effectively.
Question. Thank you. Matt, where are we going? Hi.
Hi. So we're in a fragmented information environment now, and that's likely not to change back to the way it was, with a more regulated and centralized opportunities to reach people that are highly trusted. And given that, we do have these stronger public institutions that people have a direct relationship with. I wonder if you've considered what role a public institution like schools and education could play in better reaching and building that trust and quality information transmission in between the crises. Like how can the health system work with the education system to better educate teachers, students, parents, those kinds of things.
Take a stab at that. So it's a great question, and I don't have a great answer for it, in the sense that, you know, we're a relatively small organization. We have, you know, 300 staff. We got about 300 scientists are affiliated with the institution. So we don't have the capacity to sort of, let's go out and try to reach all the TDSB schools or more broadly across Ontario. But I do think that there's, you know, there are opportunities in combination with the health system, for example. So, you know, I'm an emergency physician. I still practice emergency medicine, and there is a program through Sunnybrook, and other hospitals, to actually take clinicians into high schools, in particular in racialized communities, to expose individuals to the healthcare system, to healthcare in general, to careers in healthcare and STEM more broadly. So I don't think it's just about healthcare. I think it's also about science literacy. It's about understanding how information is produced and how misinformation is produced. So I do think there's a role for our institutions to play in that, whether it's a healthcare or a research institute. I think the resources are limited. So the question is, how do we do that effectively? How do we combine forces so we're not all doing a bit of the same thing less effectively? How do we leverage each other? And I think that really is you know, requires all hands on deck. I don't think we're there yet.
Yeah, I would agree with that. And what I would add is that, you know, just the general skill of critical thinking, you know, even outside the narrower context of health information, but just giving people the skills they need to be able to recognize, you know, this is good information, this is bad information. How do I question this? How do I go deeper? Is sort of one area for exploration. It's really interesting, you know, how some jurisdictions are now restricting kids from having access to their phones and their social media during school. And you know, you may or may not think that's a great idea, but it may provide an opportunity to sort of use those formative years to have, you know, these periods of time where people where the kids are not you know, co-influenced by something coming from outside the classroom to help build those critical thinking skills.
Matt, do we have time for one more question?
Anybody? Okay, here we go.
Hi.
More of a comment than a question. I work in correctional healthcare, so definitely not a trusted institution, and trust and power dynamics are challenging. But I think who the source of the information is really important. And we saw that a lot during COVID. It may not be the clinicians who are the trusted source to be able to convey health information to individuals. So, you know, we've been struggling with trying to ensure that we leverage chaplains and Indigenous leaders in the system, or correctional officers, and how can we kind of build that network of people who may not be, you know, initially trained or comfortable in health information, but may end up being the trusted party for individuals. So I think that's challenging, probably particularly important in marginalized communities, where who the trusted party conveying the information is matters more than anything else.
Yeah, that's pretty consistent with the community ambassador program that was implemented during COVID for the vaccine rollout. I think it was remarkably successful
In a short period of time.
It broadened out the conversation not only to vaccines, but also I think it was helpful for catching up on things like Pap tests and breast screening, and you know, taking a little broader frame than just pushing vaccines, right?
Yeah, I was just going to say, coming from Kingston and having worked a little bit in the correctional system, totally get where you're coming from. And I think it does speak to the value of, and both Helen and Michael have referred to this, of, you know, putting the good information in the hands of people who are going to be persuasive, who are trusted and respected by the communities they're serving.
I mean,
Thank you.
For the Matt.
So I want to again thank you to the speakers. Our next event you will see is coming up in June. It'll feature Mike Heenan from St. Joe's talking about workplace violence. Again, same thing. Come on out. Don't go online. Come on, have a coffee, have something to eat. Thank you so much. Have a wonderful day.